Hello everyone, welcome to chapter 19. In this chapter we're going to focus on the heart. Part 1 of our lecture is going to concentrate on the anatomy of the heart. We're going to take a look at the different chambers, the different valves. We're going to discuss how blood flows through each and exactly what governs the flow. And then towards the end part of part 1, we're going to take a look at this thing called coronary circulation, which is going to be the arteries and the veins that are specific to supplying oxygen and carbon dioxide and overall blood flow to the heart itself. Okay, so first things first. When you think of a heart, I think many of us would be comfortable in saying that we think of a pumping organ. We think of a pumping mechanism. We think of the fact that we need it to get our blood flow to circulate throughout our entire body. And you're correct in that. But also what I want to highlight for those of us who weren't sure about this is that when you take a look at the heart, you're actually taking a look at two separate circuits. You have what we like to call the pulmonary circuit, and you have the systemic circuit. The pulmonary circuit is going to be focused on the right side of the heart. And the main purpose of the pulmonary circuit is to collect deoxygenated blood. So blood that's been circulated throughout the body has dropped off its oxygen, and the right side is going to collect that blood that is low on oxygen or deoxygenated, and it's going to return it over to the lungs so we can do our gas exchange. Drop off the CO2, pick up additional oxygen. The left side of the heart is going to be concentrated on what we like to call systemic circulation. Systemic means body-wide. So what the left side of the heart is going to do is it's going to take that oxygen-rich blood that is returning from the lungs, and it's going to be responsible for distributing it throughout the rest of our body, providing every single cell with oxygen to keep its aerobic respiration and other mechanisms going. And what happens to the blood once the oxygen is derived from it? Well, we switch back over to the right side of the heart, and what we see happen is we collect that deoxygenated blood, return it to the right side of the heart, return it over to the lungs, make sure that we get new oxygen, and then we go back to the left side. And it keeps going like this, back and forth. So what you're going to notice is when you're looking at your color code keys, you will always see a blue and a red coloration, especially when we take a look at our arteries and our vein and the overall blood flow. Now, you're also going to notice that on this PowerPoint, what I've done for you is in the pulmonary circuit, the right side of the heart, I went ahead and I made that text blue. And the reason for that is because every time you see pulmonary circuit, I want you to think blue blood. Blue blood means that there's no oxygen or very little oxygen attached to it. So this is going to be our deoxygenated blood. Instead, this is the blood that's going to be filled with carbon dioxide. This is the blood that needs to return to the lungs so we can do our gas exchange. The systemic circuit is highlighted in red text because in our previous chapter, we discussed the fact that the minute oxygen binds to the heme in hemoglobin, you get this beautiful red color that develops. So anytime you're going to see red, you're going to think about oxygen-rich blood, and you're going to think about systemic circulation, and it's going to be focused on the left side of the heart and getting that oxygen-rich blood all over the body to supply the cells for their nutritional demands. Okay, so right side pulmonary, left side systemic. And don't worry, as we go throughout the part, we'll discuss each part and each chamber individually, and you'll get used to this whole deoxygenated versus oxygen-rich blood. Now, before we take a look at the anatomy inside the heart, let's see exactly where it's located within the body. So for many of us, we know that the heart sits in between the lungs. It's in our thoracic cavity. And also what we see happening is within the heart, you have what we like to call the base region and the apex region. And this is going to sound a little weird, but the base is actually the part that's on top of the heart. It's going to be its widest part. It is going to be where you're going to have all your major blood vessels. So if you take a look at your illustration, I've highlighted the base, which is towards the top not the bottom where you would expect a base to be. And on the base of the heart, you're going to notice that that is where you have your anchoring points for your aorta, the largest artery that you have in your body, as well as the superior vena cava and the inferior vena cava, which is the largest vein that you have in your body. The pointy bottom of the heart is going to be called the apex. This is going to be a tapered end, and fun fact, the apex always points towards the left, and when we do our respiratory chapter, we're going to talk about the fact that on the left side of the lungs, you have a little indentation that will be able to accompany the apex of the heart perfectly. Excuse me about that. Also, the heart is about the size of your fist, and no, it's not the shape of a stereotypical drawn heart. Instead, it will look completely different, which we'll talk about in 1 second. Surrounding the heart, we have what we call the pericardium. The pericardium is going to be a connective tissue layer that forms a double-walled sac, and it's going to have many different functions. But the most important one is that it's going to reduce the friction so that every time the heart beats, it doesn't aggravate the lungs that are right by near it. We also see that it will allow for a little bit of space so that the heart can expand as it's contracting. And also, more importantly, is that it provides a barrier, so it will make it more difficult for disease models or, for instance, cancer cells to spread or hop from one organ to the next. I always like to think of the pericardium as kind of like a little Ziploc bag that just surrounds the heart and protects it. But you can also compare it to like the meninges, so things like the dura mater that you saw when we were discussing the brain in 2085. So it's a protective layer, and its main function is reduction of friction, limitation of spread, and obviously also it will provide additional room for the heart for its overall movement. Now, do me a favor and take a look at the picture, concentrate on the top part, and then you're going to notice that they've kind of zoomed in, and that's going to create figure B for us. And when you look over there, you're going to notice that I've highlighted for you in the red box the pericardial sac. The pericardial sac is going to be the outer layer of the pericardium. Remember, it's a double wall sac, right? So that means you have an outside layer and an inside layer. The pericardial sac will be the parietal pericardium. It will be the superficial layer. And what we see happening is that it's divided by the fibrous layer and the serous layer. The fibrous layer is composed of mostly connective tissue. The serous layer is going to be a little bit thinner. It tends to be more of a deeper layer, and as you can see, it's going to be on the inside of the pericardial sac. And this is important to point out because what we're also going to see is as it's pointing inwards, you're going to have an additional layer that makes up the pericardium. This is going to be called the visceral pericardium. This one is going to be what they call a serous membrane, a very thin see-through membrane that actually covers and makes physical contact with the heart. And it actually becomes embedded into the heart to the point that the visceral pericardium is also called the epicardium. So it goes by two names, and the reason for that is because visceral pericardium will describe the sac that encloses the heart, the fact that that's the internal part that comes into actual contact with the organ, whereas the term epicardium will actually describe one of the outer walls of the heart. So the two terms indicate the same location, but one term hints towards the pericardium, the covering. The other term will hint towards the actual walls or layers of the heart. In between, you will also have what we call a pericardial cavity that's created by the folding over of our pericardium, and inside of that you'll have a little bit of fluid that will really help with reducing the friction of the heart as it's beating on average every 0.8 seconds. All right, now for those of you who have confused a little bit with the visceral pericardium and the epicardium, go ahead and do me a favor and let's look at this slide. Let's see if I can clear it up for you a little bit. So if I take the pericardium that double layer sac and I remove it from the heart, it turns out that I can really only remove the fibrous layer and the serous layer from the pericardial sac. I am not able to remove my visceral layer, and the reason for that is because it's embedded in the heart tissue itself. And when I now look at the heart all by itself with the pericardium removed, I see that the heart wall is going to be made out of 3 layers. And as you can see on the illustration, I've boxed those 3 layers in. You are going to have your epicardium, which is the outermost layer. This is the same exact layer that was making up our visceral pericardium. But now we're going to give it a different name because we're not interested in its covering ability. We're interested in the fact that this is the top layer of the heart. So the epicardium describes the most superficial wall of the heart, and it's also part of the visceral pericardium, which is the covering that protects the entire heart. It has some adipose tissues here and there, but more importantly, the epicardium, in addition to it being the superficial or the outermost layer, will also be the layer where all your coronary blood vessels are attached to. Those are going to be the blood vessels that supply oxygen and carbon dioxide pickup to the heart itself. Now, the innermost layer is going to be called the endocardium, and the endocardium is going to line the internal chambers as well as cover the valve surfaces. So if you take a look at your picture, go ahead and be able to identify the epicardium, outermost, endocardium, innermost, and then the one that I skipped is the one that's in the middle. That one is going to be the myocardium. Your myocardium layer is not only your middle layer, it's also going to be your thickest layer, and it's also going to be the layer that's made out of cardiac muscle. So when you guys did your histology chapter, you were introduced to cardiac muscle, and one of the things you had to learn about it is the fact that you can only find it in the heart. Well, here it is. It makes up the myocardium, the middle layer of the heart. This will be the layer that will cause the contraction and the relaxation. So it is the workhorse of the heart. We see that the muscle fibers will lie in a spiral pattern. Take a look at the picture with the red arrow showing you the spiral format. We will also see that it will have lots of collagen and elastic fibers embedded within it. It will not only provide the pumping mechanism, it will also provide structural support. It will help anchor the different valves that we find in the heart, and it will also contribute heavily to electrical insulation. In the next part of our lecture, we're going to talk about the fact that the heart has to generate action potentials for it to consistently contract and eventually relax. And this is all done to the fact of generating currents through our myocardium. And this is possible because they do offer electrical insulation. All right, so we now know about our pericardium, our covering. We know about the 3 walls of the heart. Now let's take a look at what kind of chambers and what kind of valves we find. All right, so we have a 4-chamber heart, which means that if I look on the inside of my heart, I'm going to see 4 separate areas. I'm going to have 2 on top. Those are going to be called my atrium. I have a better picture coming up for you, but for now, go ahead and locate the right and the left atrium. They're indicated by the top stars. Those are going to be your superior chambers, your upper chambers, and the atriums are in charge of receiving blood that's returning from the body and entering into the heart. So blood will enter into the heart with the atriums. Your atriums also have these structures on the outside called auricles. Auricle means ears. I will show you this in the picture for just a second. But what the auricles allow the atriums to do is they allow to increase the surface area so that they can collect more blood in one sitting. The 2 other chambers are going to be called ventricles. They are going to be your inferior or your bottom chambers. And the ventricles will receive their blood from the atrium, and their job is to pump the blood outside of the heart. So it will either pump it out onto the right side, which means we're doing our pulmonary circulation, or it will pump it out to the left side, which means we're going to take a look at our systemic circulation. Go ahead and make sure on the illustration, before we click over to the next slide, that you're able to locate the two bottom red stars showing you your right ventricle and your left ventricle. So 2 atriums and 2 ventricles. Here is an enlarged picture of it, and you can see the right atrium marked, right ventricle is below it, and then we have our left atrium, and then we're going to have our left ventricle on the other side. Here's a look at the anterior view of the heart. I wanted to show you this external surface because I wanted to show you the auricles. So you can see the right auricle and the left auricle. Notice how they have these little curved edges. And the auricles on the outside will help you guide where the atriums are on the inside. And remember, the main purpose of the auricle is to increase the surface area of the atrium. Therefore, it can collect more blood. There you go, highlighted. Right atrium and left atrium. Right auricle, which goes with the right atrium, and left auricle, which goes with the left atrium. Something that's also really nice is that when you're looking at a heart, even from the outside, you'll be able to see where the specific chambers are, because we see that there are these things called sulci that basically cover the outer surface. A sulci or a sulcus is basically a groove, and these grooves will often carry or embed the coronary arteries and veins that actually supply blood to the heart itself. So do me a favor, take a look at the top picture, and you're going to notice that on the box on the left-hand side, I basically highlighted the sulcus called the coronary sulcus. And once again, a sulcus is just a groove. The blood vessels are sitting inside the sulcus. So all those red and blue lines, those are your blood vessels. They're sitting inside of the sulcus. And the reason I'm having you look at the coronary sulcus is because it's also called the atrioventricular sulcus. And that groove on the outside of the heart allows us to distinguish where the atrium and the ventricle are located. The atrium is going to be above the coronary sulcus, and the ventricle is going to be the region below the coronary sulcus. You also have what we call an interventricular sulcus, so an interventricular groove. You can see it's been highlighted on the right-hand side of the illustration. You have the anterior, the one in the front, and the posterior, the one in the back. And this interventricular sulcus allows us to see the border that separates the right and the left ventricle from each other. I don't think that would come as a surprise to many of you because the name kind of reveals it all, right? Interventricle, in between the ventricles. And even the top one, atrioventricular, the meeting point between the atrium and the ventricle. So pay attention to the names because oftentimes they'll reveal a lot about the location where they can be found at. Inside the chambers, if we can just return there for a really quick second, we also have a few septums, a few walls that will keep everything divided. So whatever's on the left is on the left, what's on the right is on the right. So they're definitely worth mentioning. The first one is what we like to call the interatrial septum. That one sits in between the atriums. It's all in the name. So it's a wall that will separate the right and the left atrium. And then you have one that's very prominent. That one's called the interventricular septum. This is going to be a large wall that separates the two ventricles, making it clear which side of the heart is the right side and which one is the left side. I'm going to show you the septums in more detail on the next slide when we have a larger illustration. I'm also going to show you the particular reasons why when you look at the illustration and you look inside the atriums and the ventricle, you're going to notice that there's lots of texture in the muscles that you're looking at, lots of lines and details that they've drawn. And that's because they're trying to highlight for you pectinate and trabecular arteria. Pectinate muscle are specific ridges that you find solely in the auricles and in the right atrium. Okay, so those grooves and those textured lines that you see occurring in the atrium and the right atrium and in the auricles, that's pectinate muscle. Trabecular carnae is going to be the same concept, that it's going to be this textured lines, these ridges that you see drawn, except that trabecular carnae is only found in the ventricles, and it seems to play an important role in separating the two chambers during contraction. All right, so here's our enlarged picture. Go ahead and find your interatrial septum. That's going to be the top red box on the left-hand side. That's going to be the wall that separates the two atriums. You can also see that I've highlighted for you the ridges, so the pectinate muscle and the trabecular carnae. And go ahead and compare the texture in the right atrium versus the left atrium. You see how the left atrium is nice and smooth when you look at its internal coloring, and that's because it doesn't have the pectinate muscle ridges. All right, next I want you to focus on the red box that's on the right-hand side. That's going to be called our interventricular septum. This is going to be a prominent wall that separates the left and the right ventricle. It's really important for me to highlight the septum because for many of us, we're going to use it as an identifying marker to separate the right and the left side of the heart. And oftentimes, I'll hear things like, but why do we need to focus on the interventricular septum? Can't we just look at the apex? The apex of the heart always points to the left. So if it points to the left, I know where I'm going. Well, it turns out, especially for those of us who are in lab, when you have a specimen that you're actually cutting into, oftentimes because of the preservative that it's been sitting into and it's been packed and vacuum sealed, the apex sort of loses its form, making it very difficult for you to identify what region of the heart you're looking at. And of course, you need to know what region of the heart you're looking at because we discussed the fact that the right is for pulmonary and the left is for systemic. So they have two completely separate jobs. But also, you're going to notice in a little bit that the names of the valves will vary depending on what side of the heart you're looking at. So I always tell my students, whenever you're doing a labeling or you're looking at a dissection of the heart, once you've cut your heart open, always find that interventricular septum because that will create your barrier. And then your next option will be identify left and identify right. And the easiest way to do that is to take a look at the thickness of the myocardium muscle. So go ahead and in case you forgot, the myocardium, that's your cardiac muscle. That's the middle layer of the heart. And you can see it's labeled on the right-hand side of the illustration, second from the bottom. So compare the myocardium on the left side to that on the right side. So compare the thickness of the wall on the left side to that of the right side. And hopefully everyone will agree with me that it's thicker on the left than it is on the right. And the reason for that is the left will have to pump blood to the entire body, which means it has to have a higher point of pressure. It will have a higher pumping mechanism. And since cardiac muscle is a muscle, the more you work it out, the larger it becomes. So your left side of the heart tends to have more pressure exposed to it, which means that the muscle will be plumper, will be thicker, making it easier for you to identify left versus the thinner myocardium on the right-hand side. Now, the next thing we have to look at now that we have talked about the two atriums, the two ventricle, the interventricular septum, we need to talk about valves. Valves are going to be ways that you can open and close, or you can regulate blood flow from one chamber to the next. The main purpose of a valve is to ensure what they call one-way flow. So the blood can only flow forwards. We don't want it to ever reverse its course, so we're going to prevent backflow from occurring. Now, as you recall, since we have a four-chamber heart, we're going to need to have a few different valves. The first type of valve you're going to encounter is going to be called our AV valve, our atrioventricular valve. It is going to regulate movement between the atrium and the ventricle, all in the name. On the right-hand side, we have what we call our tricuspid valve. You can also call it the right AV valve, but most of the time it's called tricuspid because it's made out of 3 cusps. I know my list really gets the better of me with that word, but 3 cusps basically means 3 pieces of connective tissue that are lined and creating that opening and close mechanism. So 3 pieces, 3 cusps make a tricuspid valve. The left side is only going to have 2 cusps. That one goes either by the name bicuspid or mitral valve. So you have a few options. So on the right, you have your tricuspid. On the left, you have your mitral or your bicuspid valve. Both of these will regulate movement from the atrium to the ventricle. Now, a quick trick to remember which one goes where is you can either think about a rat or a lamb. RAT, R-A-T, stands for right atrium tricuspid. So the right atrium will have the tricuspid valve. And LAM will stand for left atrium mitral bicuspid. So the left atrium will have the mitral or the bicuspid valve. In addition to the rat and the lamb, we also see that the AV valve will have what we call cordia tendineae or tendinous cords, little guitar strings, little cords that come down from the AV valve and connect to the papillary muscle that's sitting on the ventricle. And the tugging of the cords is what's going to allow the valves to open and close. All right, let's take a look at this from an illustrative aspect. Okay, so notice the valves, they're indicated by the white sections highlighted with the little red boxes, and go ahead and notice how underneath the valve you have the tendinous cords, those little guitar string looking formats that are coming off the valves and they're connecting to our papillary muscle. And the papillary muscle will tug at the strings, and as it's tugging at the tendinous cords, it allows the valves to open and blood goes gushing from the atrium into the ventricle. And if we see that the blood has a tendency to reverse and come out of the ventricle and go into the atrium, we don't want that, so we're going to close the valves, thereby preventing backwards flow and ensuring only one-way flow. So right AV valve is your tricuspid, left AV valve is your bicuspid or mitral valve. The second set of valves that you're going to encounter are going to be called your semilunar valve. Your semilunar valve, sometimes abbreviated SL, will go ahead and regulate movement from blood out of the ventricle and into either the pulmonary arteries or the aorta, depending on if we're on the right side of the heart or the left side of the heart. The semilunar valves are made of 3 cusps. They do not have the cordia tendineae, so they will not have the guitar strings. And we see that we're either going to call them the pulmonary or the aortic semilunar valve. The pulmonary semilunar valves will be on the pulmonary side, which means they will be on the right side of the heart, and they will regulate movement from the right ventricle into the pulmonary trunk, which leads us to the pulmonary arteries. So this will help regulate blood as it's flowing out of the ventricles to the outside of the heart. The aortic semilunar valves are going to regulate the opening on the left side of the heart, and they are going to regulate movement between the left ventricle and the aorta. If you would like, go ahead and take a look at the pictures that have been inserted on this slide. In a little bit, you're going to see some of them enlarged, but you can go ahead and see in Figure A, you can see the aortic valve and the pulmonary valve. Those are the ones encirculated either in red or in blue. Notice how they have 3 cusps, 3 pieces that they're made out of. And then in front of it, you can see your AV valves with those stereotypical cordia tendineae. The picture in the middle of B is once again of a semilunar valve, And then C is showing you the tendinous cords that you will only find in the valves that we talked about previously, which are our AV valves. All right, so here's a better look at our pulmonary valve. And the aortic valve is tucked right behind it. If you look down 2 identifying markers, you can see it right over there. My apologies, I forgot to add the little box. The pulmonary valve and the aortic valve, they basically lie right one behind each other. So for many of us, when we're doing our heart dissection, depending on the cut we'll make, we'll only be able to see one. You can do a cross-sectional cut along the base of the heart if you want to see all 2, and in fact all 4 valves. But either way, before I go off topic, notice how your pulmonary valve does not have any cordia tendineae. You will only see those cords if you're looking at your AV valve. Here is a much better picture, so you can see all 4 valves at work. As I was mentioning to you before, you can see your aortic valve and your pulmonary valve. Pulmonary is going to be for the right side, aortic for the left. Excuse me. And then towards the front, you can see your AV valve with the cordia tendineae, and you can see how the left only has 2 cusps and the right has 3 cusps, just like your semilunar valves, your aortic valve and your pulmonary valves. All right, so we need to talk about what exactly is going to allow the valves to open and close, like what controls the blood flow, what regulates the opening and the closing. And it turns out it's all about pressure differences. So it turns out that the valves will only open to allow blood to flow from a high pressure point to a low pressure point. So let me try to explain this differently. So imagine that you are observing your heart and you're looking at your ventricle, your bottom chambers, and you notice that they're relaxed. In general, when the ventricles are relaxed, they're a little bit enlarged. They're just kind of like an open sac. Nothing exciting is happening. And what we see happening is, as they relax, the pressure becomes lower and lower and lower. And at a certain point, what we see happening is the ventricle is so relaxed that the pressure within the ventricle is lower than the pressure in the atrium, which is the chamber that's above it, right? And whenever the valve that regulates the atrium and the ventricle, your AV valve, notices that the pressure in the atrium is higher than the pressure in the ventricle, the valve will go ahead and open up and blood will go rushing into the ventricle. Now, as the blood is rushing into the ventricle because your AV valve is open, we see that the other valve, the semilunar valve, is closed. And the reason it's closed is because as the ventricle is filling up with blood, its pressure is slowly starting to increase, but it's not higher than the pressure that you have outside of the heart, so by the aorta or by the pulmonary arteries. And because the pressure is higher outside of the heart, the valves will stay closed. Eventually, the ventricle will start filling up with blood to the point that it can start contracting. And when it starts contracting, we see that the pressure starts rising. And we're going to see a few things happening. As the pressure rises, the valves that control the AV movement, the atrioventricular valve, are going to notice that the pressure in the ventricle is higher than the pressure in the atrium, which means that blood will have a tendency to go from high to low. It would have a tendency to backflow. And when it sees that happening, the AV valves are going to close off. Done. Because we don't want it to go backwards. We only want to do it one way. As the pressure continues to rise, then what we see happening is that there comes a period of time where the pressure inside the ventricle is higher than the pressure in the pulmonary arteries or in the aorta. And the minute that happens, the minute that the ventricle is contracted to the point where it has a higher pressure point than the great arteries, the semilunar valves will open up and blood will gush out of the ventricles into your pulmonary arteries and into the aorta. So what regulates the opening and closing of the valve? pressure differences. The valve will only open if the pressure is higher in the start point than it is at the end point. And I'll show you this in an illustration, okay? So hold on for 1 second. Now it says, how does this regulate, or how does this relate to the heart sounds? Well, if you've ever listened to the heart, and if you haven't, you can go ahead and Google oscillations of the heart. You'll hear the dum, dum, dum. Okay, I'm not the best at making sounds, okay, so don't laugh at me. But either way, when you hear that heart sound, you tend to hear two sounds, what they like to call the lub and the dub. Da-da-dum, da-da-dum. The first sound you hear is actually when you close the valve, the blood will hit the back of the valve. Bam! And as it's hitting it, that's the sound that you hear. The second sound is when the semilunar valves close and the blood hits the back of those valves. That's your second heart sound. So your heart sounds are basically just blood hitting the back of the valves, making sure that there's no backwards flow. And as it hits the valves, it makes the sounds that you hear. We'll talk more about that. Don't stress. I just kind of like to introduce you to things as we're going along. Let's go back to the opening and closing of the valves for now. Okay, so take a look at this illustration. And what we see happening is, in figure A on the left-hand side, it says the atrioventricular valve is open. So whatever's happening on the right is happening on the left. The AV valves are open on both. This can only happen if the pressure in the atrium is larger than the pressure in the ventricle, because blood will always go from high to low pressure. So if your AV valves are open, that means that we want blood to flow from the top chamber to the bottom chamber. And then notice now on the other side of the image that as blood is flooding into the ventricle, the pressure starts to increase. The minute that the pressure in the ventricle is greater than the pressure in the atrium, the blood would tend to reverse its course. Notice how the green arrows are now pointing upwards towards the atrium. The valves are there to prevent that backflow from happening. So your AV valves will close off if the pressure in the atrium is less than the pressure of the ventricle. Or you could say the pressure in the ventricle is greater than the pressure of the atrium. So your valves will always regulate that one-way movement. And they're there because blood will always flow from high to low. Now, before I switch over to the next slide, I want you to try to answer this question, okay? What would the scenario have to be when it comes to pressure points for us to open the next set of valves? So for us to open our semilunar valves. So take a few seconds. I'm going to wait 5 seconds before I click over. But try to figure out if I want my semilunar valves to be open and I want blood to flow from the ventricle to the outside of the heart. Where does the pressure have to be higher for the valve to be open and when will the valve close? Here you go. So it says if the semilunar valves are going to be open, I'm looking on the left-hand side of my screen at the illustration, the pressure in the ventricle has to be greater than the pressure in the vessels, so in the blood vessels. And this goes for both the right and the left-hand side. We can see that the blood is flowing from the ventricle to the outside. Follow the green arrow. The valve will only be open if the pressure in the ventricle exceeds the pressure in the blood vessels. Eventually, as blood leaves the ventricle, the pressure starts to drop. And as it drops, there will come a time where the pressure in the ventricle is less than the pressure in the great vessels. And at that point, we're going to notice that the blood will have a tendency to flow back. Notice how the green arrow now on the right-hand side of my illustration is pointing back to the ventricles. At that part, what we're going to see is that your semilunar valves will close off, preventing blood from flowing back. And as the blood tries to flow back, it will hit the back of that valve, and that will then create those heart sounds that I was just mentioning to you previously. Okay, so you have your AV valves, you have your semilunar valves, and they will only open if the pressure is high to low to allow for one-way flow. All right, this then now leads me to a very exciting part of the chapter, which is getting to talk about blood flow throughout the entire heart. I am so excited about this slide. I put a big old star next to it because on your upcoming exam, I will tend to ask you several questions about how blood flows and if it's in this chamber, through which valve will it go, to what location will it go to next. So I really want us to take our time and I want us to get familiar with this. And if you know the blood flow through the heart, you'll also know all the different names of the chamber and the valves and the blood vessels. So as I'm rattling along, please make sure to take a look at the right-hand side of your illustration where it's been written out for you, all the different blood vessels and chambers and valves, and then obviously also to peek on the left-hand side so we can follow the numbers as we move along. Okay, so first things first, I just want to remind you of the color code. So remember, blue is for deoxygenated blood, and red is for oxygenated blood. And also what we'll see, and you'll really encounter this more in our next chapter when we do our worksheet on chapter 20 on the blood vessels, is we'll talk about the fact how some blood vessels will carry blood away from the heart and others will carry blood back to the heart. The blood vessels that carry blood away are arteries. A is for away. So anytime you come across a name like pulmonary artery, carotid artery, femoral artery, if you see that it has the term artery in it, that means you're looking at a blood vessel that carries blood away from the heart, and chances are that that blood is going to be oxygenated, which means it's going to be shown as red. There are some exceptions to that rule. If the blood vessel is blue, it will often indicate what we call a vein. A vein carries oxygen-poor blood or deoxygenated blood. That's why it's blue. And veins tend to return blood to the heart. So if you come across the pulmonary veins, the jugular veins, the subclavian veins, anytime you see veins mentioned, you're going to notice that from an illustrative aspect, they'll be drawn in blue, and they will go ahead and return blood back to the heart. Now, I mention this because when you look at your first step for blood flow from the chamber, you're going to notice that we're going to start off on the right atrium, and it's going to tell you that the right atrium will receive its blood from the superior and the inferior vena cava. The vena cava is the largest vein that we have in our body. The superior is the one that's above the right atrium. The vena cava is the large blue tube that's sticking out towards the bottom on the left-hand side of the heart. Both of them have the number 11 written above them. So that is going to be your vena cava. Blood will flow through the vena cava and it will enter the heart through the right atrium. From the right atrium, our next step will be to pass through our right AV valve, also called our tricuspid valve, and go into the right ventricle. From the right ventricle, we will pass to number 3, which is the pulmonary semilunar valve, which will bring us over to the pulmonary trunk, and it will divide into the pulmonary arteries. So the pulmonary arteries will carry blood away from the heart over to the lungs. So we're going to drop off the carbon dioxide. We're going to pick up the oxygen. And now we're going to rely on number 6. Find it in your illustration. Number 6, the pulmonary veins to take this blood that is returning to the heart. And now with the pulmonary veins, we're going to go over to the left atrium. From the left atrium, we're going to go over through the mitral or bicuspid valve into the left ventricle. And finally, from the left ventricle, we're going to exit through our pulmonary semilunar valve, which is hidden behind the pulmonary valve. So we're now between numbers 8 and 9. Blood will flow from the left ventricle through the aortic semilunar valve into the aortic arch, and away it goes throughout the rest of your body dropping off oxygen and picking up carbon dioxide. And once it has circulated through the systemic circulation, courtesy of the left side of the heart, we see that it will return back through the vena cava into the right atrium, and then we can do it all over again. So, a few notations, and this is a little bit premature because we'll talk more about it when you do your blood vessel labelings in the next chapter, is notice how if you look over at, find number 5 for me. Number 5 are your pulmonary arteries. They're arteries because they carry blood away from the heart, but notice how the arteries are not red. In this case, they're labeled blue. The pulmonary artery is an exception to the rule that all arteries carry oxygen-rich blood. They don't. The pulmonary artery carries blood away from the heart, which is what makes it an artery, but it carries deoxygenated blood away from the heart over to the lungs. Thereby, the color scheme is blue. On the other hand, your pulmonary veins, look for number 6, they return blood to the heart, which is what a vein does, but notice how it's not blue, it's red, because these particular veins, the pulmonary veins, they will carry oxygenated blood back to the heart. Okay, so make a little notation for yourself. This will come in handy for both your lecture as well as your lab, that normally arteries are red and veins are blue, with the exception of the pulmonary artery and the pulmonary vein. And it all has to do with blood flow through the heart. Oh, what's that? You want to repeat the blood flow? I'm so happy you asked. Let's do it. All right, so we have the numbers, but we don't have the text. So let's see if you can follow along with me. All right, so deoxygenated blood, which has circulated throughout the body, will be collected in our veins, and it will enter the right atrium, number 1, through the superior and the inferior vena cava. From the right atrium, we will pass through the, number 2, our tricuspid or right AV valve into our right ventricle, and then we'll pass through number 3, the pulmonary semilunar valve into the pulmonary trunk and out through the pulmonary artery, number 5. At this point, the deoxygenated blood is brought to the lungs. Inhale, exhale, drop off that carbon dioxide, pick up that oxygen, make that blood nice and red, and we see that the blood returns through our pulmonary veins, number 6, into the left atrium, through the mitral or bicuspid valve, into the left ventricle, and on our way to the aortic semilunar valve, through the aorta, right there in number 9, and from number 9, it will do its systemic circulation, and it will spread across all the different arteries, circulating throughout the entire body, dropping off the oxygen and picking up the carbon dioxide. Please expect that on your exam, you'll have questions along the way that will be kind of like fill in the blank, where I will say things like, for instance, when blood enters the right atrium, through which valve will it flow next? Through which chamber will it flow next? So please make sure that you know your blood flow. Please make sure that you know your one-way flow and that you know your specific valve, both the AV and the semilunar valves. All right, now to quickly finish up part 1 of this particular lecture, let's take a quick look at coronary circulation. Coronary circulation is going to take a look at the blood vessels that actually supply oxygen and carbon dioxide to the heart. The heart is an organ, so it does have metabolic needs, and on average about 5% of the blood flow in our body is dedicated to this pumping mechanism. So I've inserted a little illustration to show you how the blood vessels will do a lot of collateral circulation, meaning that they'll share different locations of the heart. So in case one becomes blocked, there is still an alternative pathway to supply the tissue with oxygen and clean up its metabolic waste, i.e. keep it pumping. All right, now I don't want you to worry about memorizing all the different blood vessels that go into the coronary circulation, so I've just highlighted the major of them. And for those of you who want to kind of know the rest, don't worry about it. In our next chapter, you'll be able to encounter it, as well as in future chapters as we go along. So this will just be a little bit of an introduction. All right, so for our artery supply, I definitely want you to know the LCA and the RCA. That's the left coronary artery. This one is going to be able to supply blood to the ventricles as well as the anterior 2/3 of the interventricular septum. So that's your LCA. The RCA is going to be your right coronary artery. As you can see, both of them will come off the aorta, which is that major blood vessel you encounter as blood leaves the left ventricle. And the RCA is going to supply the right atrium as well as your SA node, your sinoatrial node. We're going to talk about that one in a little bit. Angina pectoralis is basically what you encounter when you have a patient that comes in and will complain of chest pains. Usually what that indicates is that the heart might have a partial obstruction within its blood flow. So imagine if you block up parts of the RCA or the LCA, what can happen is that you could start having ischemia, shortness of oxygen in those cardiac muscle cells, and that shortage of oxygen will cause the cardiac cells to switch over to anaerobic fermentation, the production of ATP without the use of oxygen. As a result of this, it will produce lactic acid. That will then cause a pain to be noticed on the receptors on the heart, and that pain is the angina that the patient will complain about. If the patient has frequent angina pectoris, that's usually a precursor that they might be at a very high risk category for developing a heart attack. A heart attack is called myocardial infarction, and that usually means that there has been such an amount of loss of oxygen in the myocardial muscles that now the cells have started to die off. And when cells die off in patches, it disrupts the electrical signals that flow to the heart, making it harder for the heart to beat in unison, and as a result it interrupts the circulation through the body. So oftentimes you see with heart attacks is that we have to treat the patients as soon as possible, and we often want to make sure that blood flow is restored so that it doesn't cause additional harm or additional death to the myocardium. The trouble is that oftentimes the symptoms are different in men versus women. So I added this little chart. This is from the American Heart Association, and I wanted to definitely add it because a lot of people will say to me, well, when someone is having a heart attack, don't they just kind of like reach for their right arm or their left arm and they're like squeezing their arm, and that's like how you know? And I'm like, yeah, on TV. Yeah, you'll see the patient reach for their arm and you'll hear someone scream, they're having a heart attack. And yes, it's quite common that the patient will notice that they have a squeezing or a pain sensation in their chest. But take a look at this chart. You're going to notice that for men, it's a lot easier to identify symptoms of a heart attack than it is for women. So you'll notice that both of them will share things like nausea and vomiting. Both of them will have squeezing of the chest, pressure and pain. But it turns out that in men, it's a whole lot more common to have that pain in that particular area. Women will often have things like they get a headache, they'll faint, they'll notice indigestion, they'll get really tired. These are all symptoms that most of us have experienced on a week-to-week basis because we just think it's part of our day-to-day routine. So for women, it's often a lot more difficult to identify symptoms of a heart attack. However, it's good to kind of be informed. And also, a lot of women will say that they've noticed that their jaw hurts. And that is then also one of the most common symptoms in women that they might be suffering from a heart attack, pain in the jaw. Our final slide for this particular part is going to take a look at the veins. So we talked about the arteries that supply the heart. Now let's take a look at the veins that are going to drain the deoxygenated blood away from the heart and obviously return it back into circulation. So over here in your PowerPoint it says 5 to 10% of coronary blood will drain directly into the heart, mostly through the right ventricle by the way of Thespian veins. Thespian veins are just very small, multi-layered veins that wrap around the heart. We also see that the coronary blood can return to the right atrium by way of the coronary sinus, which is this large chamber that sits towards the back of the heart. We're going to see it again in a little bit. But blood collected or pooled in the coronary sinus will go ahead and be emptied out into the right atrium. And once the blood is returned to the inside of the heart, we see that it will just join together with overall blood flow. And then it just goes along its way with the valves ensuring its one-way flow. All right, everyone, that's the end of part 1. I'll see you in a little bit for part 2.